everybody. Today we have a very pertinent topic to discuss about, a topic which is low risk early prostate cancer post radical prostatectomy, which has local recurrence with high risk features N0, M0. Would we give radiation to it or versus chemotherapy? And I would be presenting the aspects of chemotherapy. I have a disclosure, I'm a RAD-ONC and I truly believe in science. And we will take it, we will put the points towards the chemotherapy as we go along. So first of all, I would like everybody to understand the question that has been addressed. It is low risk early prostate cancer post radical prostatectomy with local recurrence, however, with high risk features, N0 and M0. And as the evidence you all know is pointing towards radiation, my radiation colleague will be talking about it lately. I will still want to, at the end of the topic, guide your minds towards a little bit of concentration towards the chemotherapy aspects and why we should consider chemotherapy in this very high risk feature group. So basically, we all know what high risk actually means, and there have been many classifications. The DAMECO classification, NCCN, EUA, and the RTOG, they all state that PSA more than 20, Gleason score by 7, or T2C to 3A patients, they will be the high risk groups. And why is this high risk prostate cancer very important? Is because they actually consist of about 15% of the localized disease, 30% of them develop metastatic disease, and 50% die at almost approximately 10 years of time. The management conventional has been already discussed about earlier, and it consists of EBRT and ADT, surgery plus EBRT or plus minus ADT. So actually, the various clinical trials and studies, they have looked around and hovered for high-risk features, and they have consisted on high-risk prostate cancers are those cases which have a high Gleason score, which have time from primary therapy to PSA recurrence of less than 3 years, which may have a PSA velocity which is more than 0.7 milligrams, nanograms per milliliter per year, and which have also a short PSA doubling time. And as my previous speaker has already said, that many of these high-risk patients, they harbor the germline DNA repair mutations, which is found in about approximately 9% of the population. So what did the EUA and the SIOG ISTRO guidelines tell us about these high-risk diseases? They actually stratified low-risk biochemical recurrence into high-risk biochemical recurrence. And the low risk consisted of those patients who had a prostate-specific antigen doubling time of more than 1 year and a Gleason score of less than 8 after radical prostatectomy. And a high-risk group consisted of those patients who had less than 1 year, basically doubling time, and the Gleason score was 8 to 10. And what did they see? They saw, after doing an external validation of all the patients that they had, that the low-risk group had a probability of metastatic progression-free survival less as compared to the high-risk group, which was obviously would had to be the way. And not only that, but also the probability of cancer-specific survival was also less in those patients with low-risk group than against the high-risk group. So it is very important to understand the question in that we had to address, that these prostate cancers are recurring with the high risk features. So even there have been many records that ADT has even not worked in these category of patients in the metastatic setting also, and people have to add on the chemotherapy regimens like the taxanes in the metastatic setting, so that that would prove a more aggressive therapy to the systemic components of the disease. And we have a lot of evidence in the metastatic setting. So there was a basis of chemotherapy, definitely, because prostate cancer is a heterogeneous entity. The androgen dependent and the independent clones, they cohabitate together. There's a strategic option, and it should be to use a combination of drugs that act on various populations in early stages and prevent the development of resistance. The low risk group behaved very differently from the high risk group. So we have to take high risk group as a separate entity totally. And hence these patients with high risk prostate cancers may also benefit from the additional chemotherapy. So having said that, what is the evidence of chemotherapy into practice? There have been many prospective randomized trials using adjuvant chemotherapy in high risk cases. And the TAX 3501, the RTOG 9902, and many other trials, some of them which are ongoing are there. And you can see that many of these trials, earlier trials, they have terminated because of early accurate termination, low enrollment of patients into these groups. So if we can consider few of these very important studies, the RTOG 0521 study, they classified high risk, they randomized them into two arms, the androgen suppression plus external RT arm, and the other was the androgen suppression plus external RT plus the docetaxel arm. And mind it, these two arms are involving androgen suppression as well, not just radiotherapy. So what they saw after median follow-up of 5.1 years was the curves were separating, and the 4-year overall survival rate was 89% versus 93% in favor of the chemotherapy arm. And even the disease-free progression-free survival rate was better, 55% versus 65% in favor of the chemotherapy arm. So, but however, they also realized that there was a lot of toxicity arising from the chemotherapy that was in question, and the grade 3 to grade 5 toxicity was 22% in just the RT as well as the androgen ablation arm, whereas it was about 65% in the arm that combined the chemotherapy. There was another study, which was the GETOX 12 study, and this stratified patients again into high-risk groups into two arms, the ADT 3 years, and they included docetaxel with exemestane for 4 cycles with local treatment, and local treatment alone in these trials. And the updated results, as you can see, shows that there has been an advantage in the term for primary relapse-free survival as well as clinical relapse-free survival for the taxane arms or the chemotherapy arms that were being given. The CHARTED trial is another EORTC trial which studies chemohormonal radiotherapy versus androgen ablation. 6 cycles of docetaxel was given in the experimental arm, and you can see that the curves are separating not only for the probability of survival but also for the recurrence-free survival. Now comes the Stampede trial, which has been the cornerstone of these studies. And actually, as you can see, that this was a multi-center, multi-arm study, and inclusion criteria included not only the metastatic patients, but also 39% had locally advanced non-metastatic prostate cancer, as you can see, and the patients who all had a high-risk group. They were all high-risk group, and you can see over here that the standard of care plus versus the standard of care plus docetaxel in this arm scored much better as the standard of care in docetaxel was concerned. So you can see the forest plot over here, and you can also state that for all the areas like nodal status, Gleason score, metastatic status, etc., they all had better survival as for chemotherapy was concerned. So these all 4 trials, they tell us, or 3 or 4 trials, they tell us that integrating chemotherapy with radiotherapy and ADTA improves the DFS and the recurrence-free survival generally. The RTOG, the GETOX 12, and the Stampede have shown, and there is also an improvement in the overall survival, which is shown in the RTOG 0512 trial. However, there's a need for longer follow-up to validate such positive results, and high-risk patients may benefit more with chemotherapy. And as we know, we have seen that many of these patients were high-risk in these study groups. There is another trial, which is, this is basically a systemic review and a meta-analysis of the additional of chemotherapy on high-risk prostate cancers, and done by our Chinese counterparts. And in this, they have shown that in a non-metastatic rather than metastatic setting, the benefit of combination of docetaxel to ADAT did not prove to be as clear-cut in terms of overall survival as in the metastatic setting. There was only 2% absolute benefit, 22 and the P significance was only 0.22 in the meta-analysis. So failure rates were significantly reduced, however, from 30% to 22%. So there was not much of significance as terms as clinical significance is concerned. So what did they consider? There was another trial by Stephen Otard, and what they said that effect of adding docetaxel to androgen deprivation therapy in patients with high-risk prostate cancer with rising prostatic antigen levels after primary local therapy. It was a randomized clinical trial, open label, phase 2/3 trial, but it was a superiority trial, and with 28 centers in France, enrolled patients between 4th June 2003 to September 25th, 2007. And the final follow-up was, however, conducted in 2017. Stratification was by local therapy, PSA level doubling time, and intention to treat analysis. And the interventions was to receive ADT 1 year plus docetaxel 70 milligrams per meter square, or just ADT alone. The main outcome levels were the primary PSA progression-free survival, secondary endpoints for PSA response, radiological performance free survival, progression-free survival, and overall survival, as well as safety and quality of life. And as you can see, the arms were very, very well characterized. They were stratified between the two arms. The groups, patients were stratified. And you can see over here, even the forest plot, they favors ADT plus docetaxel to almost all the groups of patients, except, of course, the less than 8 Gleason score patients. So they have taken out their median follow-up after 10.5 years. And they have said that of course, the radiological progression-free survival was significantly better in these patients, but as far as the PSA, as far as the comparison for docetaxel and ADT alone with patients in high metastatic, non-metastatic prostate cancer, docetaxel additionally added 15% benefit in time to progression-free survival, but however, it did not add to the overall survival benefit. There's also a trial of adjuvant docetaxel after surgery, and this trial has shown that 6 cycles of docetaxel given to those patients after radical prostatectomy has shown a significant survival benefit in terms of survival probability percentage. So what do we conclude from all these very, very evidences that we have for chemotherapy in the prostatic cancers for the localized disease? We have a conclusion that there have been a lot of barriers to completing the prospective adjuvant prostate cancer trials because of long follow-up time needed for completion, lack of validated early endpoints, confounding relationship between the testosterone and the PSA in trials using the PSA-based endpoints, lack of consensus regarding what constitutes the high-risk disease was different in different trials, new standards that may compete for enrollment, required long-term monetary support, and etc. Several possible reasons may also be responsible for the absence of the significant difference in overall survival. First of all, the overall survival was affected by crossover treatments, which was there allowed in many of these studies. Patients may receive other active treatments such as albuterol or enzalutamide beyond progression. The chemotherapy regimens and number of cycles administered were different for different study groups. The total number may have been docetaxel 7 cycles in one study, followed by, and it was seen that 7 cycles at least was a better overall survival advantage than against just 5 cycles. So they actually took out the meta-analysis. You can see over here, the GETUC, the RTOG, the Stampede, the overall survival, the control and the treatment groups, and the forest plots. So overall, they showed that the overall survival was tending towards betterment in terms of docetaxel arm, but it was not statistically significant. However, the failure-free survival was definitely significant in favor of docetaxel with a statistical significance. So where do we go from here? Now we've heard about all the chemotherapies and what it will do. It will actually maybe not add to the overall survival, but it will add to the progression-free survival of these patients. Do we just dump chemotherapy down the lane because maybe it has not come to the end point? The end point has been overall survival in these trials. Or do we go this way for radiation or that way for chemotherapy? Or maybe we can have personalized treatment for these group of patients which are high risk group. So what I want to implicate at this point is that case selection is prime time. The objective is to identify the subgroup of patients with the least favorable prognosis and the treatments that best match their genetic characteristics. As said earlier, about 2% of the prostate cancer patients that carry hereditary BCA mutations, while 12% of these patients have sporadic mutation. And we have to launch more better designed trials to assess the new treatment strategies and the therapeutic potential of novel drugs for prostate cancer in these settings. There are better biochemical markers like the telomere marker, and it has been seen that men with combination of more variable and shorter telomere marker have 3.76 times the risk of prostate cancer than death than against 2.23 times the risk of progression to metastasis as against those who had less variable telomere length. So telomere biomarker is a robust associated with poor outcome independent of the current pathological indicators in surgically treated men, and this has to be explored. We all know about basically the genomic classifier, that is the Decipher, and it has correlated very well with the NCCN stratification, and you can see that the low risk does better as against the high risk. The high risk actually fares much worse. In India itself, we have seen that the incidence of de novo metastatic prostate cancer is very high, which means that we might be a population which harbors the more aggressive of the disease. So as we come to talk about the quality of life after chemotherapy, there have been difficult situations. There have been, of course, side effects, but these side effects were manageable and practically evened out after 1 year of treatment, which has to be kept into consideration.
I think your time is over. Try to finish.
Yes, the last slide, sir. Proper case selection and multinational randomized control trials needs to answer these questions. Of course, we need more personalized medicines for the right choice, the right drug, the right indication, and promising efficacy with the addition of chemotherapy or novel therapies, and further long-term data is required. More refined risk categorization based on clinical and molecular information is required. More data is still required to establish the benefit. But till then, I would just ask you to think over that early evolution to the AR independence is there in high-risk patients. So we need to act fast and maybe address the problem. Thank you so very much.
Thank you, ma'am. Over to Dr. Sharon Das for his talk.
Hi, a very good evening to all of you. So can you see my screen?
Yes, we can.
Well, so again, I would like to thank the organizers for arranging this program and giving me the opportunity to participate in this debate. So as my previous speaker, as well as the moderators already explained, that we have been given with a clinical scenario. And I would request the participants who are listening to this, just keep this in mind. So a low risk early prostate cancer post radical surgery now has a local recurrence with high risk features. So it's basically a non-metastatic castration sensitive prostate cancer scenario. And we're talking about radiotherapy versus chemotherapy. Now, before we begin, you need to know about the natural history of progression. Remember that even after a biochemical recurrence, these patients tend to have a prolonged natural history. And studies have looked into it to find out the factors that may predict the risk of metastasis or even death. And they found out that a Gleason score of 8 to 10, a shorter duration from surgery to PSA relapse, and a short PSA doubling time are probably features that suggest a high risk of developing these distant metastasis, based on which the EAU did this risk stratification system, which my previous speaker has already alluded to. Now, what do the guidelines say in this scenario? So post-surgery, PSA persistence or recurrence, NCCN says EBRT with or without androgen deprivation therapy. Observation is for the very low risk group. What does ESMO have to say? Similar scenario, localized disease. After surgery, what does ESMO say? Salvage radiotherapy to the prostate bed, with or without to the pelvic nodes, and consider ADT for 6 to 24 months. No mention of chemotherapy anywhere. What does the ASTRO guidelines say? Well, they've defined salvage radiotherapy as administration of radiotherapy to the prostatic bed and possibly to the nodes in patients with a PSA recurrence after surgery, but no evidence of distant metastatic disease, the exact scenario that we have been given with. And they also suggest that salvage radiotherapy can provide long-term disease control. So where is the debate? Let's dig deeper. The initial retrospective studies mainly focused on biochemical relapse-free survival, trying to find out which group of patients were most going to benefit. And what was shown or what was seen is that patients having a low PSA level at the time of recurrence and those having a long recurrence-free interval following initial surgery tend to have better biochemical relapse-free survival. But this begets the question, what about improving survival with salvage radiotherapy? Well, unfortunately, there aren't any randomized data answering this question, but there are several retrospective studies of large number of patients. Can't really ignore them. So 26, close to 2,700 patients data from Mayo Clinic, where they showed that salvage radiotherapy significantly reduced the incidence of subsequent local recurrence with an astonishing hazard ratio of 0.13, but no difference in overall survival. What does the study from Johns Hopkins, 600 patients, again showed there is significant prolongation of cancer-specific survival in patients who received radiotherapy with or without ADT, and the benefit was limited to those having a short PSA doubling time. However, the results from the Duke University suggest that there is improvement in all-cause mortality with salvage radiotherapy, irrespective of whether you have a PSA doubling time of less than 6 months or more than 6 months. Again, hazard ratio of close to 0.5. Before I go any further, just a word of caution. We have been told that it is a non-metastatic scenario. Now, it's not given whether that is based on conventional imaging or not, because nowadays there is emergence of the next generation imaging, that's this PSMA PET CT scan, which can give us a more accurate information about the exact disease extent. And there is trials, the Empire 1 trial, which has shown that in this scenario, in a biochemical relapse setting, a PET guided radiotherapy compared to conventional imaging based radiotherapy led to improvement in 3-year event-free survival as well as improvement in failure-free survival. So when do you offer salvage radiotherapy? Again, no randomized trials answer this question, but prompt initiation of salvage radiotherapy is probably more appropriate as it has been found to be more effective based on retrospective data. 2,500 patients data from 10 tertiary cancer centers suggests that if you have a lower serum PSA prior to starting salvage radiotherapy, you tend to have better 5-year freedom from biochemical failure. So if your PSA is less than 0.2, it's 71%, versus PSA more than 2, it comes down to 37%. Another study from the Mayo Clinic, 1,100 patients with the serum PSA less than 0.5 had a significantly lower incidence of biochemical relapse, distant mets, as well as cancer-specific mortality. Is it too toxic? Well, not really. We have retrospective data, database study, which shows that with post-op radiotherapy, out of which 80% was salvage radiotherapy, rates of late grade 3 or more GU or GA side effects was less than 1%. You want randomized data? I'll give it that as well. The Radicals RT trial, which compared immediate post-op radiotherapy versus early salvage radiotherapy. I chose Radical RT because that was the largest of the 3 studies that have been recently published. Look at there, at the end of 5 years, so late toxicity more than grade 2, so grade 3 or more, less than or 1%. Remember these values. I'll come back to it later on. So now, after establishing that there is a role of salvage radiotherapy in this scenario, let's talk about the role of systemic therapy. Well, systemic therapy, yes, probably an alternative if the patient refuses salvage radiotherapy or is not a candidate, which is very unlikely unless it's very, very old or very poor performance status. And there is a role, I agree, if there are features which suggest that there is a high risk of disseminated disease. But there are no randomized trials that have compared the role of ADT versus observation in this scenario of a patient having a biochemical relapse. And the efficacy of adding more agents to ADT, be it docetaxel or ribavirin or enzalutamide, they have not been conclusively established in this scenario. There is evidence in a metastatic setting, in a metastatic CSPC, these agents are approved. But in a non-metastatic scenario, these are not approved. And why it is important, I just put a single interesting comment, is remember, drugs that work in an adjuvant setting, they definitely work in a metastatic setting, but the converse may not be true. So if the drug does work in a metastatic setting, does not necessarily imply that it works in adjuvant setting. So let's go into the evidence. So evidence of adding ADT to radiotherapy, again, ASTRO recommends that it should be added when you are planning for salvage radiotherapy. Madam has already alluded to the phase 3 GETA AFU16 trial. We did show that yes, there was an improvement in 5-year PFS as well as in 10-year PFS if you added ADT to radiotherapy. But what about RTOG 9601? 760 patients with a biochemical recurrence following surgery, randomly assigned to radiotherapy plus or minus bicalutamide for 24 months. 12-year overall survival, significantly better, 76 versus 71%. But the devil lies in the details. A post-hoc secondary analysis showed that the OS benefit was observed in patients having PSA levels more than 0.6. In patients who were receiving early salvage radiotherapy, that's what we suggested, that you start early. Bicalutamide not only did not improve overall survival, it in fact increased other cause mortality. And there was increased risk of late cardiac and neurological side effects as well. The SPORT trial, 3 arms, randomized trial, 1,800 patients, similar scenario, prostate bed radiotherapy alone versus RT plus short course androgen deprivation therapy versus you add pelvic nodal radiotherapy as well. The trial is still ongoing, but they have done a pre-planned interim analysis which showed that if you add short-term ADT, it did improve 5-year freedom from progression, but no significant benefit in freedom from distant metastasis or overall survival. Look at the curve. The arm with pelvic radiotherapy added had the best results till now compared to the other arms. Again, Madam has already spoken about the genomic classifier scores, which yes, has been associated with distant metastasis as well as prostate cancer specific mortality based on this ancillary study of the RTOG 9601 trial I just now showed. However, what it showed in addition, again, as I said, the devil lies in the details, is if you add bicalutamide, the benefits are less in patients having a lower GC score. Again, in patients receiving early salvage radiotherapy, use of bicalutamide was again associated with a lower overall survival, as you can see from this curve here. What about early androgen deprivation therapy versus deferred ADT? Series from the capture database showed there is no difference in overall survival between early initiation of ADT within 3 months versus when you start ADT at clinical progression. It is seen from the curves on the right side. See, they're kind of hugging each other. An observational cohort study analyzed close to 6,000 patients. Again, no significant difference in overall survival or even prostate cancer specific survival with early androgen deprivation therapy. You want randomized data? The TOAD trial. Randomized between for early versus deferred ADT. It was terminated due to slow accrual, although it did show a benefit, but it was grossly underpowered to come to any definitive conclusion. Now, I would ask or request my participants to ponder upon some of these points. As I said, patients with a biochemical relapse, they have a prolonged natural history, and metastatic disease may not become evident for many years. You remember, Madam showed a curve about the validation of the EAU risk stratification. Even there, the 10-year median metastasis-free survival in patients having high-risk features was close to 70%. Similar results from this retrospective study of 800 patients. So those having a PSA doubling time less than 6 months had a metastasis-free survival of 144 months, that is 12 years. So your patients will be free from metastasis for 12 years without any systemic therapy. You still want to start ADT early for them? Remember, next time in your clinic when you offer ADT, it causes significant side effects which can worsen the quality of life. Think a patient who has no symptoms, just a rising serum PSA level, and you want to add treatments that are going to worsen his or his quality of life, because patients experience hot flash, fatigue, loss of libido, weight gain. 20 to 25% of patients will have significant osteoporosis, increased risk of diabetes mellitus, cardiac disease. Think before you offer treatment. What about adding chemotherapy? The Stampede trial that Madam alluded to, landmark study, Docetaxel led to significant improvement in overall survival when added to ADT. But subset analysis, the very forest plot that Madam showed, the very portion that she highlighted, I would ask my participants to have a look at that as well. See, the benefit was in the metastatic group, no benefit in the M0 subgroup. You want randomized data? French randomized data that Madam already showed, no difference in PSA progression-free survival or in radiologic PFS, even at the end of 10 years. The TAX 3503, another multi-center phase 3 trial, similar setting, high risk biochemical relapse post-surgery, ADT for 18 months with or without docetaxel. The curves, look at them, they're just hugging each other. No difference with regards to PFS or overall survival. And not only that, look at the risk of grade 3 or more adverse events. In the ADT plus docetaxel group, 48%. Remember what I showed with the radicals RT data. To conclude, with this scenario that we were given with a non-metastatic CSPC, the cure is the aim, and radiotherapy is a keystone in the management of these patients. Salvage radiotherapy is the modality of choice. The key is early salvage radiotherapy. Start early. Next-gen imaging has a very, very important role to play to choose your patients. The role of genomic classifiers is coming up. It may help to guide treatment. ADT is useful in patients with a relatively higher PSA. The benefit of adding chemotherapy to ADT is still unproven. I thereby rest my case. Thank you.
Thank you.